Hello, my name is Fleur, and today I've been called to a 37-year-old male called Garud who has chest pain and shortness of breath. Despite the notes in the EMDT, it is important when you enter a job that you don't develop tunnel vision. Your first assessment should be AVPU, Alert Voice Pain Unresponsive. This is a shortened version of the GCS. Next, have a look at your patient. What position are they in? How does their skin appear? What status do you place them at first glance? If you see that your patient is in the tripod position with nasal flaring and or accessory muscle use, this could indicate that your patient is in respiratory distress. If so, then you need to make sure that your questioning is closed questions, like do you have a history of asthma? Do you have any allergies? With this patient, it is important to gain a quick respiratory rate, SpO2, and auscultate the lungs. Entering the scene, I can see that my patient is not in respiratory distress. There is an increase in respiratory rate of 22, but there is nil accessory muscle use, nil nasal flaring or tripod position. My first question is going to be an open question, and it allows me to assess my patient's words per breath, GCS, and their primary chief complaint. This is going to answer the question of whether we can stay in play or whether this is a diesel job. Okay, hello, my name is Fleur. Can you tell me what is happening today?
I've got a really horrible chest pain. I've been feeling hot and cold and it's finding it hard to breathe.
Okay. Do you have any medical conditions?
No.
Are there any regular medications that you take?
No medications. I take a multivitamin.
Okay. And how about any allergies?
No, none that I'm aware of.
Okay. Asking about medical conditions and medications gives you an insight to possible causes. Allergies is also another important question to ask, as if the patient happens to deteriorate, we know what we can and can't give them. Another reason we need to know about allergies is in case they are having an allergic reaction. Next, I'm going to further investigate Garud's signs and symptoms, starting off with his chest pain. Garud, can you tell me, when did this chest pain all begin?
It started this morning, came on a bit quite gradually throughout the day.
And can you describe how it feels?
It's just, I suppose, a dull ache.
Can you take a deep breath for me? Did that change the pain at all?
Yeah, it increases the pain when I breathe in. Take a deep breath.
Okay. And can you show me where you're feeling this pain?
Just about here.
Can you feel it anywhere else in your body?
No.
Okay. And if I have a scale of 0 to 10, 0 is no pain and 10 is the worst of your life, where would you place it on my scale?
Probably a 7.
A 7, okay. Would you mind if I had a feel of your pulse? Is that okay? I just want to take one of your wrists. Alright. So feeling Garud's pulse, we can feel that it is regular and it is strong. So that's a good sign, and it's at 80 beats a minute. Other vital signs that we're experiencing are blood pressure at 130/90. His SpO2 is at 100, his temperature is 38.2, and his BGL is 6.4. Now, traditionally with a patient who doesn't have diabetes or hasn't had an altered level of consciousness, we wouldn't do a BGL, but a BGL can be a good indication if there is an infection. The next assessment we want to do on our patient is an ECG. Now, with any patient, when you are taking any sort of vitals, it's important that you first ask before taking them. With an ECG, we know that we're going to be placing the chest leads across the breast area. So it's very important that you gain consent, and you may find that some patients would prefer someone of the same gender doing it. Looking at my patient's 12 leads, they appear to be in sinus rhythm. However, this doesn't outrule any cardiac conditions. But at this stage, I'm going to move on to the patient's breathing to see if we have an underlying respiratory condition. I'm going to start off by auscultating my patient's lungs, and I want to make sure that I look at the front and the back. With our patient, whenever you're looking at their chest or their back, also have a look to see if you can see any injuries, any bruising. Is the chest moving equally? Can you see any changes to the jugular veins? Any of these sorts of things can indicate something else is going on. Now, Garud, I would like to have a listen to your chest. Are you okay with that?
Yeah, that's fine.
Before we carry on, can you tell me, have you been coughing up anything at all?
Yeah, I've been coughing up a bit of green phlegm lately.
Okay, and how long have you had that cough for?
Oh, maybe last week.
Last week?
Yeah.
And have you seen your GP about it?
No, I haven't.
Okay, when we auscultate, I'm going to start at the front and I want to make sure I get all fields of my patient's lungs. So I'm just going to get you to be nice and comfortable and I'm going to get you to focus on your breathing while I have a listen, okay? Okay, that's great. Take a seat. Having a look at my patient's chest, I can see no signs of recent trauma and no signs of bruising. Listening to their lungs, there is equal air entry into the upper lobes. The lower left lobe has a reduced air entry and the breathing appears to be shallow. Double checking his respiratory rate while auscultating, I found that the respiratory rate was 22 breaths a minute. Some common causes of shortness of breath can be asthma, COPD and anaphylaxis. After talking with my patient, I found they had no known medical conditions, no allergies, and the only regular medication they took was a multivitamin. Asthma, COPD and anaphylaxis can all present with shortness of breath, chest discomfort and a wheeze. Anaphylaxis can also present with stridor. I saw no systemic signs of anaphylaxis and feel it is unlikely that my patient had asthma or COPD given their medical history. Looking at my patient's vital signs, we can see that my patient is febrile and borderline hypertensive, tachypnea and tachycardic. My patient stated that over the last week they'd had a productive cough with green phlegm. On auscultation I could hear no abnormal lung sounds, however there was diminished air entry into the lower left lobe. All of these signs and symptoms led me to believe that my patient has a lower respiratory tract infection, which can be anything that affects the bronchial tubes and includes conditions like lung abscesses, pneumonia, and bronchitis. Given that my patient has had a productive cough, is febrile, feels short of breath, and has chest discomfort which is made worse on deep inhalation, I believe that they have developed pneumonia in the lower left lobe. Auscultation of the lungs can be diminished or you may hear rales or crackles with pneumonia. This is due to pus buildup in the air sacs, which can be caused by a viral or bacterial infection. Now with any infection, you want to have a look at where your patient sits on the sepsis spectrum. The first stage is SIRS, which is Systematic Inflammatory Response Syndrome. During this stage, an infection has entered your system and your body is trying to fight it. In order to confirm SIRS, our patient must have at least two of the following: a temperature over 38 or under 36 degrees Celsius, a heart rate over 90 beats per minute, respiratory rate over 20, and the white blood counts can be either over 12,000 or under 4,000, which is obviously done in a medical centre. The next stage in our spectrum is sepsis, which is SIRS plus a confirmed infection. My patient meets this criteria. Based upon the sepsis spectrum, my patient's lower respiratory tract infection has led to sepsis, and if it is left untreated, it could lead to septic shock, which is a life-threatening emergency. Septic shock can lead to multiple organ dysfunction syndrome, which leads to death. While talking to my patient, they also stated they had chest discomfort. Now, when you have a patient with chest discomfort, you should always perform a 12 lead. After assessing my patient, I found that they had central non-radiating chest pain that was described as dull in nature and made worse on deep inhalation and had an intensity of 7 out of 10. The ECG showed sinus rhythm and my patient had no known cardiac conditions. My patient showed no signs of a STEMI, however this does not rule out a non-STEMI which does not show ST elevation on a 12 lead but can cause the same damage to the heart as perfusion is reduced due to a blockage. While I believe that it is unlikely that my patient has a cardiac condition, always have a low threshold for transporting patients with chest discomfort. Thank you, and I hope you have a lovely day.